name is Lieutenant Mangano, and today we'll be discussing an introduction to the ESI system for the emergency department nurse on orientation. By show of hands, how many of you think OB complaints are considered high acuity? Most of you guys would say no, but based off my experience as an ER nurse, I feel differently. So a 28-year-old healthy woman presented to the emergency department at 13 weeks pregnant. She complained of an increased vaginal bleeding over the past hour. Typically, OB patients are triaged as ESI level 3 based on their low acuity, and the interventions can be anticipated in advance, such as a transvaginal ultrasound, urine, blood work, etc. But during this bedside triage, this patient was in 10 out of 10 pain, visibly uncomfortable, pale, and she was diaphoretic. Further assessment of her vaginal bleeding revealed she had saturated 5 OB pads in the past 45 minutes prior to her arrival and 3 while in triage, and she also passed 2 tennis ball-sized clots, which is very significant. When we started cleaning her up, I noticed that her pants were also saturated in the blood, and she was sitting in a pool of her own blood. At this time, I deemed her to be an ESI level 2. In my opinion, she was in acute distress, hemodynamically unstable. Within 30 minutes, the patient had 2 large bore IVs, IV fluids going, blood was sent to the lab. We had sent paperwork down to request blood products. She was at transvaginal ultrasound. An OB consult was waiting for her in her room, and he took one look at her when she got back, and she was sent to the OR for DNC. The ESI level system is vital to efficient and quick patient care, especially for patients like this who we normally would not consider high acuity. At the end of this lesson today, the novice emergency department nurse on orientation will be able to apply content to the Emergency Severity Index, or ESI, to accurately triage and assign ESI levels to the emergency department patient. They will be able to categorize emergency department patients in the appropriate ESI level categories with the ESI conceptual algorithm, assess the emergency department patient in triage, and assess an accurate ESI level based on the 4 ESI decision points. Proverbs 22:6 tells us to train our children so they can use their gifts appropriately. This is true for training the novice ER nurse in the emergency department early, so when they are the expert nurse, they will remember their training and be able to train the future generation of novice nurses. The ESI triage scale was developed by emergency department physicians Wurtzert and Itzel in the United States. The ESI is an algorithm tool used in the emergency department by the triage nurse to separate patients into 5 groups based on their acuity and resource needs. The levels range from 1, which is the most urgent, to 5, which is the least urgent. The ESI system facilitates the prioritization of patients based on the urgency of treatments for the patient's condition and who the provider should see first. ESI 1, the provider should see immediately. ESI 2, which is emergent, they can be seen within 1 to 14 minutes. ESI 3 is urgent and should be seen between 15 and 60 minutes. ESI 4 is semi-urgent and they can wait for about an hour to 2 hours. ESI 5 is the most non-urgent patient in the ER, and they can wait between 2 and 24 hours, depending on patient volume and acuity at the time. So why use the ESI? ESI is simple to use and reduces the subjectivity of the triage decision. Rapid identification of patients who need immediate attention will lead to improved patient flow through the emergency department. It is also the most accurate triage system to date. ESI 1 and 2 patients will be taken directly to the treatment room, while ESI 5 patients can safely wait to be seen. Various triage to clinic protocols allow ESI 4s and 5s to be sent to other areas in the emergency department or even to clinics or urgent cares, along with some ESI 3s. For example, a patient who just needs a simple migraine cocktail can be sent to an urgent care nearby for treatment. Using the ESI system greatly improves the patient flow in the emergency department. Research has shown that nurses have reported that the use of the ESI tool facilitates effective communication about the patient's acuity. For example, the statement, "I need a bed for a level 2 patient," effectively addresses the patient will need 2 or more resources and that they are unstable in some way. The goal of the ESI system is to accurately report acuity and resource needs to other nurses and providers in the emergency department. So using this patient as an example, let's triage her together using the ESI system as an introduction. A 27-year-old woman presents to triage with dry, cracked lips and states, "I am 7 weeks pregnant and every time I eat, I throw it back up." The patient's vital signs are temperature 98.2, heart rate 110, respiratory rate 18 breaths per minute, blood pressure 148/90, oxygen saturation is 98%, pain is 0 out of 10. Patient states she has had these symptoms for the past 72 hours. So does this patient need immediate life-threatening intervention? No, the patient is not high risk or in acute distress, although she is uncomfortable. Is the patient able to wait for a bed in our waiting room? I would say definitely yes. She is not unstable. What resources can we expect for this patient and why? So I would predict for her, we would give her an IV, some fluids, maybe some Zofran. We'll do a PO challenge. We might do some labs depending on what the doctor thinks, because she does have an elevated heart rate, she has dry, cracked lips, and she is not tolerating PO. From our breakdown of this patient, her ESI level would be a 3. So this is the ESI conceptual algorithm. It is intended for the use by nurses with triage experience, the experienced emergency department nurse, or those who have attended a separate comprehensive triage educational program. Patient acuity is determined by the stability of vital functions and the potential threat to life, limb, or organ. The triage nurse estimates the patient's resource needs based on previous experience with similar patients presenting with similar injuries or complaints. Resource needs are defined as the number of resources a patient is expected to consume in order for disposition decisions, so like discharge or being sent home or being admitted. The triage nurse will be able to triage patients rapidly and accurately into one of the 5 defined and mutually exclusive levels, which he or she is fully oriented to the algorithm. So our first decision point on the ESI decisions will be, does the patient require immediate life-saving intervention? If the patient is in need of a life-saving intervention, they are triaged as an ESI level 1 and a team response is initiated with immediate physician involvement. Examples of life-saving intervention will include intubation, assisted ventilation, surgical airways, cardioversion, needle decompression, control of a major bleed, or medications such as adenosine, Narcan, dopamine, or dextrose, and this is not a mutually exclusive list. Examples of interventions that are needed but not considered life-saving would include oxygen administration, EKG, a fast exam, and medications such as aspirin and nitroglycerin. Immediate physician involvement is the biggest difference between ESI level 1 and ESI level 2. Life-saving interventions are aimed at securing an airway, maintaining breathing, supporting circulation, or addressing a major change in level of consciousness. So some examples would be cardiac arrest, anaphylactic shock, a flaccid baby, or an overdose with a respiratory rate of 6. Hemodynamic interventions, which do not include IV access, supplemental oxygen, cardiac monitors, EKG, or labs, but do include intubation, a patient that is apneic, pulselessness, respiratory distress, or pulse ox less than 90%, or an acute mental status change, which would be evaluated with the AVPU scale, or the patient is just unresponsive. And unresponsive is defined as a patient who is either nonverbal and not following commands acutely, or requires noxious stimulus, which would be a P or U on the AVPU scale. Our second decision point will be, can the patient wait to be seen by a provider? A patient who is high risk is a patient whose condition could quickly deteriorate or presents with symptoms which may require time-sensitive treatment. The triage nurse can initiate the protocols in the triage room for an ESI2 patient, and various interventions can be done prior to needing a physician. If a patient is confused, disoriented, or lethargic, there's indication that the brain may be chemically or structurally compromised. Example, a new onset of confusion in an elderly patient is a good indication that they need to be seen quickly. If the patient self-reports their pain to be 7 out of 10 or higher, the triage nurse can assign an ESI level of 2, but they do not have to. Most patients who rate their pain 7 out of 10 or higher, it can be relieved by a simple intervention by the triage nurse, such as applying ice to the area, a wheelchair, or elevation to the extremity. If you as a triage nurse are willing to give your last open bed to a patient, they warrant an ESI level 2. Our third decision point is going to be what resources are needed. The triage nurse should ask themselves how many resources are anticipated for the emergency department physician to reach a disposition. This decision can be made by the experienced triage nurse reflecting on past patients in addition to the brief patient assessment to anticipate what resources will be needed for each patient. So examples of resources would be a lab, EKG, a CT, MRI, IV hydration, IVIM, or nebulized medications, a specialty consult from OB or surgery, or simple complex procedures such as sutures, a moderate sedation, etc. Not resources would be an H&P, point of care testing, just a saline lock, oral medications, tetanus, med refills, a phone call to primary care, or simple things such as crutches, splint, slings, and simple wound care. The fourth decision point is what are the patient's vital signs? Are the patient's vital signs within or outside the normal limits for the patient's age, as you can see by the table on the screen? You should consider an up triage to an ESI level 2 or the next triage level for patients exceeding the danger vital zone criteria. Pediatric fever considerations. 1 to 28 days of age, you should assign at least an ESI level 2 if rectal temperature is over 100.4. 1 to 3 months of age, consider ESI 2 if rectal temperature is over 100.4. And 3 months to 3 years of age, you can consider an ESI level 3 if the rectal temp is over 102.2, or they have incomplete immunizations, or there's no obvious source of fever. Based on the patient's history and physical assessment, the nurse must ask if the vital signs are enough of a concern to say that the patient is high risk and cannot wait to be seen by the provider, which in that case you up triage and get them to your next available bed. So now that we have more information about the 4 triage decision points for the ESI system, let's review this case study. A 16-year-old female is brought to the emergency department by emergency medical services who hit a tree while driving 55 miles per hour. The patient was not wearing a seatbelt. The patient is moaning and moving all 4 extremities when she arrives. Her initial vital signs are blood pressure 70/48, respiratory rate 36 breaths per minute, heart rate 148 beats per minute, oxygen saturation is 99% on a non-rebreather, and temperature is 98.4, and she has a GCS of 7. So again, using the 4 triage points, let's work through this case study of the 16-year-old patient together. Is this patient in need of immediate life-saving treatment? I would say definitely yes. The patient needs to be intubated with a GCS of 7. This patient cannot wait to be seen. She is deemed high risk due to the mechanism of injury and severe distress with ventilation compromised with a GCS of 7. Resources that we can anticipate are a CT, X-ray, IV fluids, blood, IV medication, blood work, urine sample, surgical consult. The patient's vitals are definitely in the danger zone. She has tachycardic at 140, tachypnic at 36 beats or breaths per minute, and hypotensive at 70/48. So based on all this information, we can definitely triage this patient as an ESI level 1, and she will be seen immediately by a provider. So now that everyone has a good understanding of how to use the ESI algorithm and the 4 decision points, each student will have 15 minutes to perform a simulation to assess and assign an appropriate ESI level based on the 4 learned decision points to patients in the emergency department using our simulation mannequin, and we will debrief as a group after. Students who are waiting for their simulation will practice assigning ESI levels with me until it is their turn, so please see me for the worksheets.